Hey everyone, welcome back to Paint the Medical Picture podcast. I want to give you all just a quick bite of information for the medical professionals, the medical coders, the auditors, the billers, the compliance professionals that are out there, as well as, of course, our trusted and reputable providers and practitioners. So, we've had some time to digest all of our evaluation and management code changes since everything took a overhaul. There was a big swing, right, to the outdated 1995 and 1997 coding guidelines that our practitioners were well aware of since the mid-90s, right? So it was high time that a sledgehammer came down on all of those guidelines because I myself do not favor them, do not like them, do not like that I have to still utilize the coding books from those years when I have to audit services that fall into a range before 2021, right? So, I still have to be fresh and current on bean counting and the like, but I am very, very happy with the new overhaul of coding guidelines for evaluation and management specific to the office and other outpatient settings. And of course, the shift also took hold in 2023 when all of that guideline shifted over to the inpatient space. As well as for our emergency department spaces, right? So all of that has transitioned over very, very nicely over the years. And as I look down here on the corner of my computer, it is 2026, right? So we've had a number of years to understand the new guidelines and try to implement those types of documentation standards into our EMRs. However, I still see that sorely lacking in the everyday auditing that I perform. And I know I've talked about this on the podcast for a number of episodes over the years. This is my 17th season. So, I know I've been talking about it for a very long time. I've written a number of articles on this very conundrum, on things that I continue to see. So I really do applaud those providers that I do audit on the regular. They've really taken my guidance and my education very, 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 very nicely. And they have accommodated to the new guidelines and their structure of their EMR templates in their EMR systems or their EHR systems. They've really spoken to some key player. Again, I've advised them to speak to their key player on their own organization who can communicate with the EMR or the EHR vendor. They are also partners with you, right? So it's key that someone on your team can play really nicely with someone on their team because it really is all about them, right? Long gone are the days. It's very rare for me to see a full-blown medical record written out the way my dad used to do, right? I just took a wonderful trip with him to India, had a great, great time. But of course, in the back of my mind, I'm thinking, thank goodness he has retired because, he was not one to be able to handle the electronic medical record system, right? He's not very computer savvy. I have to help him a lot with his iPhone. It's a good thing that we just text each other, FaceTime each other, and play Wordle together. That's about all he uses. Oh, and he also plays his Sudoku on his iPhone. So anyway, but I digress. As usual, when it comes to my dad, I always like to bring him and talk about him on the podcast. One of these days, I should really interview him, shouldn't I? And then you guys will know exactly who I'm talking about. A genius, and he really could have utilized the new HCPCS code, that G2211 code. I know I've talked about that for a number of years on the podcast as well, with his longitudinal relationship with his patients as a former internal medicine practitioner in the United States for just under 40 years. He really, really, really could have utilized that HCPCS code very, very swimmingly. In my opinion, his documentation would have held up to my standards for sure. Again, because he used to write everything down, and when he couldn't write all of that, he would dictate everything, right? Also very, very simple to do. It's just a matter of, again, having a great relationship with your dictation vendor, right? Who is going to go ahead and translate all of that onto paper, onto the EMR, right? So anyways, I digress as usual when it comes to my trusty tips and something I'm very passionate about, which is E&M services in the office space. So anyways, I do have providers that I teach regularly when it comes to beefing up their E&M services. So I've recently put them on a 6-month schedule. They've really improved their documentation. I've definitely elevated them to my standards, right? Much more supportive to all of the payers in their payer matrix. So if they ever get called back from a Cigna or a Blue or a MAC in their region, they will pass the scrutiny, right? I have walked with them in documentation improvement for not only documentation for documentation itself, for documentation integrity, but for the revenue cycle, right? So they can be happy with the reimbursement that they receive based on their payer contract, right? So, there's so much we have to consider when it comes to auditing, when it comes to that either internal auditor like I am, I'm a player on their team, right? So even though I'm external, right, I'm not in their office every single day, I'm definitely a player on their team. I'm not an external auditor per se, which would be someone who comes in from the outside from a commercial payer or a government payer, something like that, right? So, I've definitely given them many, many gold stars over these past few months because they've really, really taken to heart exactly what it is I've been saying in terms of making improvements. So I always love to advise my specialty providers, definitely take it piece by piece, right? Column by column. Our providers are very used to the 3 columns, right? The problems addressed. Obviously, we are practitioners and we want to talk about the problems that our patients are walking in the door for. What are they walking in the door for today, right? Are they complaining about their knee pain? Their right knee is very, very sore today, like my mom, right? Osteoarthritis. It's now bone on one of her knees, sadly, right? So we know she will have to get a knee replacement. But over the years, right, we've had to do those knee injections, the visco supplement injections, the various name brands that had to go in there, the corticosteroids, etc. But she's a Medicare patient, right? Again, I talk about her in my presentations over the years as well, because you're a Medicare patient, right? And there are LCDs, those local coverage determinations that take effect, right? And so you really have to be cognizant of that fact and do the research. So what are the bells and whistles, those hoops that our providers have to jump through to make sure if we can bill for that type of visco supplementation injection to my mom, what does she have to meet beforehand, right? There's lots of criteria beforehand that have to be met. So for those problems addressed, what are we talking about today? We're talking about that right knee pain. Then what are we going to look at for that center column? All the scary data analyzed, right? That's the stuff that our practitioners love, right? Inside and out, the data analysis. They are very rational, level-headed people that need the data to help support their guidance, right? Where will they guide their patient? How will they treat them, right? It's the data that's going to tell them what to do. So in that particular date of service on that day when my mom comes to the office, what's Dr. Smith going to do? Is Dr. Smith going to order any x-rays? Yes, he is. He needs to see the progression of that knee. What's going on? Is the osteoarthritis getting worse? Is it stable? An x-ray should help him understand what is going on. So sure, he wants to order those x-rays. So there's a certain number of views that happen in x-rays. So that has to be documented. And we have to make sure that when we're auditing that documentation, that we're taking a look at those views of the knee, right? Is it documented somewhere in the body of the note, as well as in that written formal interpretation report that is also required for that level of CPT code? So he might do some other things. He might draw some labs on her, just again, based on her presentation, based on her other problems. And this is a general practitioner. This is not the osteo guy, okay? So this is general. So she very well may need some labs, high blood pressure checkup, whatever. She might need all of those things, right? Then when it comes to our last column, the risk to the patient and or the risk that the procedure may have on the patient management, right, for that particular date of service. So what is her Dr. Smith going to do for her knee pain on that day? That is the only problem that she's complaining about on that day, but she does need a refill on a prescription. So right there, we already know that because he did talk about the high blood pressure, she's having some issues. That's definitely been addressed. A problem has been addressed, so that diagnosis code will be put on the claim, and it is in the documentation. So that prescription management for level 4 in that column of risk is going to be supported. So right there, because the documentation is perfection, I've already reviewed it, I've audited it, it's spot on, right? They talk about the medication, the dose, the why does she have to take it, and how many times a day does she have to take it, how many times a week, etc. Right? So that's all been really well written out. Now, what about that knee pain? Are they going to progress to injections? Are they going to progress to just watch and wait? My mom doesn't want to do any more needles. She's terrified of them. What about that knee replacement surgery? Oh no, I'm not ready for that yet either, right? If I don't like needles, why on earth would I want to be cut and put under anesthesia? So all of that in some professional form can be documented in the note as well, that my mom did receive all of the tips and the risks of all of these procedures, how they will help her or how they will hinder her, right? So all of those things can be documented in the note. So all of that for my particular clients have been really, really vastly improved because I slow down and I teach them column by column how to make improvements in their documentation, right? Because many providers that I have as clients are very, very used to, obviously, right? It's been over 26 years that they've been stuck with 1995 and 1997 guidelines. It's been forever. So all of that older, outdated education has to be undone, right? So to undo something that someone is so used to, it's become a habit, right? We have to break that habit and make newer habits and start calling them standards for today's landscape. Because the AMA made these new guidelines to help our practitioners in their everyday work, right? Help them make sure that the documentation is there for the patient, right? That's the patient's record, right? And we've had all of these new laws that are now better protecting our patients, right? Patients like myself, I'm also a patient. So, hey, when I take a look at my ER visit from a couple years ago, right? Now I know better, right? What was going on with my body. But at the time in the ER, right? It didn't really warrant a level 5, which is what it was billed for, right? So, but again, I was the patient, right? I can't audit my own note, but there was many, many problems there on why that ED level was picked at a level 5. And so even though I tried to dispute it, whatever, I just acquiesced and said, whatever, get off my back. Let me just get rid of this, right? So that's what I had to do from a personal standpoint when I went to the ER a few years ago for health conditions, but everything's fine, right? I'm still here. I didn't die. It was not a level 5, right? But again, because there's a misunderstanding, that particular team at this hospital that's really, really good right here around the corner in Chicagoland, that's what they chose to bill it at, right? So many things that could be improved there as well. And I've helped many AER physician as well better document and better understand how to code things. It's not just all about the highest level, the level 5, because the patient is in the ED. Definitely if they're on their way to expire, right? If they've had a heart attack, they're unconscious, et cetera, you've had to have a full workup on that person to bring them back. Absolutely. For things like that, well documented, you definitely can support it. But hopefully you guys got a lot out of my very quick trusty tip today. But I did want to address all three columns, and my advice is always to slow down and take your education to your providers column by column. And I promise you will help them tremendously for their own practices, for their own documentation standards that they now understand. And it can also help you, right, as a provider educator, as a physician advocate. It's definitely my way of doing things, and I love it, because when you go in and speak to a practitioner, you have to have the right tone, right? It's all about the people skills. It's all about the soft skills. We know our physicians, our practitioners are geniuses, right? They went to medical school, residency, fellowship, right? They took many, many years out of their lives to educate themselves to take care of the people, right? So the least we can do is give back if our forte and our expertise happens to be on documentation, writing, communication. If we can help them, that's all it's about. And it's about making it easy for them to understand, because they are very, very busy people. They are high thinkers, critical thinkers. And so the more you give them quickly, they can digest. And so I always recommend doing it column by column for this particular trusty tip today for the E&M section of codes for the office and other outpatient settings. It really goes a long way. And so I cannot thank my providers and practitioners enough that I've helped out there. I love doing it. It makes me very, very satisfied and very, very happy that I am a business of healthcare professional. So I hope my audience today at Paint the Medical Picture podcast got a lot out of this. I'm happy to come back again for another trusty tip and talk about things one column at a time in more detail, and just keep one trusty tip focused on problems addressed. I can take another episode and just talk about the data analyzed, and I can take a third episode and talk about risk to patient management. So there's lots more I can do for Paint the Medical Picture podcast. There's so much to talk about in healthcare. There are thousands and thousands and thousands of codes and places of service and modifiers and HCPCS codes and DME and payer policy. So much to unpack from episode to episode. So my audience is never bored. All right, you guys, thanks so much. And I really hope I see you again next time. Bye.